sorry, it will be in English because my Spanish is not as good as my PhD student, so it's here. And she presented a few years ago, I think, a few weeks ago, her project. That's why I'm visiting the lab here too, because we have some field work to do next week. Okay, so thank you for the invitation. I will present a bit my research, but not only my research, but the research of my group. Because I have several, the picture is not really up to date, but it's almost the team. Because I have several PhD students and postdoc who work with me in a group that there is no official name, but it's on health geography. Most of the people there are geographers, but not all. We also have one veterinarian, one statistician, and most of them work on mosquitoes, but not all as well. Some work on zoonosis, but you will see that in the presentation. So health geography, what it is, the definition from the dictionaries, the study of the dynamic relationship between health and place. So here the territory, which is a space that is multifactorial, a multifactorial construction is at the heart of the approach. We ask the same basic question as any study in geography: who, what, where, or when. It's more descriptive. That's more the descriptive part, and then we try to go to the why and why there and not elsewhere. So to go to the explanation step, and yeah, these are basic questions in geography, but here we apply it, of course, to health questions. So we work a lot with that kind of maps, risk maps, so to try to better target interventions. And I work especially in low resource settings in Africa, where it's very important to target the hotspots, the most at-risk areas. So here it's a map you maybe know from Alan on the risk of emergence of zoonosis. It's a map that includes both environmental and some human factors like population density. And that kind of map is not new. It's done from quite a long time ago, especially, and it's expanded a lot since we have remote sensing and satellite images. But most of these maps are still based more on environmental variables that are easily extracted from remote sensing, temperature, especially climate, humidity, and vegetation. But you will see here that in our research, we really try to go further in that and also include more human variables. So, and we base a lot of our work on that conceptual framework. So the risk could be a vector-borne or any other risk. It's actually based on a disaster risk management framework. The risk is divided in two main boxes: the hazard. The hazard here, we see the hazard as the presence of infected vectors. So it will mainly be environmental variables like climate and vegetation that will influence the distribution of mosquitoes or any other vector, but also the distribution of the parasite or virus, depending on the disease. And then the second box is the vulnerability, and that includes all the more human variables, I would say. And so there is the exposure, so people need to be at some place at some time to be exposed to the hazard to get infected. There is the susceptibility, so some people are more susceptible to get the disease than others, depending on genetics, on demography, and biological factors. And then the resilience, it's another aspect that is also important. It's the capacity to anticipate, the capacity to cope, also the capacity to recover from the disease. So we include in that also the questions of access to healthcare, for example. So we really need both hazard and vulnerability to have the risk, and then we can also, in terms of interventions, we can act on the different boxes. We can have intervention that specifically targets the vectors, but we can also target more human variables to play on the exposure, for example. Okay, so just to start a short example, this is the risk of the disease for malaria in Dakar, Senegal. Work was done by a colleague in the ULB, in University of Brussels, Sabine Vernuijs, maybe you know? Yeah, okay. She did a very nice work of using very high resolution images to map here it's first the hazard, so the suitability, the habitat suitability for the vector. So mainly using climate and vegetation data. Then it's the mosquito-borne project. And then for the vulnerability, there are also some layers about the build-up structure, the population density. We produced a very high resolution population density map for the city of Dakar. And also in the mosquito-borne project, they mapped deprivation. So they categorized the neighborhoods of the city in planned or unplanned environments, and there are different land use classes that help to map deprivation. These two layers were included in the framework. So we have hazard and exposure that were combined using some weighting scheme based on expert knowledge, but I will not enter in the details here, to provide that kind of risk map from very low to very high. There is different categories of hazard: low, medium, or high hazard, and then low, medium, or high population density. So of course, the red category, where we have high hazard and high population density, is the most at risk area. So this is the illustration. So I now divide my presentation in two parts. I'll try to give a kind of overview of all what we do in the research group. I will not enter into details because I don't have time, and also because most of the work is not done by me, so I don't know all the details. But a first part is more about some data and method development on which we work to improve the vulnerability layers, because there are lots of variables that are difficult to include in the risk maps because we don't have data on them, or we need to be a bit creative to include these variables in the models. And then in the second part, I will present 3 of the current PhD projects we have in the group at the moment, and that's built on this. So regarding vulnerability, first, the population at risk is key. As I just said, for any risk assessment, we need to know how many people are at risk, how many people are exposed to the risk. If you have a risk, if you have a hazard but nobody living around, there is no risk. Okay, so first question is, how many people are there and where are there? And I wanted to mention WorldPop because WorldPop is a big project that you probably know. It's yes, I see people saying yes. That's very good. No, I spent a lot of years during my postdoc working on WorldPop, so I know very well these maps. I'm not involved in the development anymore today, but I was actually developing all the maps for Africa. At that time, the project was called AfriPop. I worked on that, on the first version of AfriPop. Was me. But then the project evolved a lot. Now it's a big team of more than 20 people. They provide open access gridded population maps for the world at 100 meters resolution. And it was until a few weeks ago, it was until from 2000 to 2020, but now they recently released the beta version until 2030. If you haven't seen that yet, it's a good time to have a look. The idea behind WorldPop is to disaggregate census data from administrative units to pixels. So most of the time, and especially on the region I work in Africa, the census data are poor quality, too coarse, or too old also. So we use machine learning models, a random forest, to look at the relationships between series of layers, GIS layers. Yes.
They are not listening so good online, so maybe you can check if the microphone is.
¿Pero se escucha?
Se escucha bien, ¿eh? Ahora no se escucha.
Hola, sorry. No estamos escuchando.
Creo que sí.
Ahora.
Ok.
Ahora se escucha.
Sí, ahora sí.
Se cambió de micrófono, no entendemos bien qué pasó. Apaguen los micrófonos así.
Si quieren apagamos la cámara para que le llegue más nada.
No, se había cambiado el micrófono.
Se había cambiado el micrófono.
Okay, this is a work done by a former PhD student on Dakar again, where he combined census data with remote sensing data to define profiles, neighborhood profiles, and link these neighborhood profiles with the mortality profiles in the city. Regarding the characteristics of the population, another PhD student, Camille, who is at the end of the PhD, she will defend next month, worked on the interpolation of DHS indicators. I suppose you are all familiar with DHS, so demographic and health surveys that provide a lot of information on the population. So you see examples of socioeconomic indicators that are provided in the surveys. It's a survey. These are surveys that are done consistently in a series of countries, especially in Africa. So it's very useful. We have data for cluster points. So one point is a cluster, is a group of households. The spatial location of points is not exact because there's a small dislocation for privacy issues, but it can still be used for that kind of analysis. The precision is enough for that kind of interpolation we use after. So for Camille works on malaria, on risk maps for malaria, and she tested different interpolation methods to produce continuous surfaces of DHS indicators. So you have the examples here. You have socioeconomic indicators and also some indicators that are specific for malaria. So the idea is simply that to go from the point to a continuous gridded surface. And she tested 6 different methods. Some methods are like random forest and Bayesian include predictors. Other methods are only based on distance, like inverse distance. And I'm not sure I put the result. Yeah, no, I didn't put the results, but it was quite interesting to see that all the socioeconomic indicators were better predicted using random forest or Bayesian model. So when we include predictors, the predictors are similar to the one we use in WorldSpot, for example. It includes the climate, vegetation, land use, land cover, distance to roads, distance to rivers, that kind of thing. But on the contrary, the malaria prevention measures were better predicted with inverse distance. So very simple method without any predictors. We thought a lot of why, but we think it's mainly due to the way the prevention is organized. For example, they distribute bed nets in health districts, and it's not necessarily the number. So the number of people having bed nets is not necessarily linked to socioeconomic profiles, but more on where they live and if in the health district if they were also distribution or not. So it's our main hypothesis regarding that. But it was quite interesting to see that according to the indicator, the best method is not always the same, and sometimes the simplest method is better than complex ones. Okay, last thing regarding the vulnerability part, it's also the movements, because all what I showed until now, it's for static population, but of course people move. So it's the last question, who do they move around? And in epidemiology, it's also important to have information on movements to the risk of transmission of emergence is also dependent on the movement. And for that, I wanted to mention a few things. So in the past, I worked with mobile phone data we had the project, for example, on Namibia, also looking at malaria and the link between seasonal movements and malaria incidence. Mobile phone data are quite difficult to access, and it's more and more difficult. So now and especially one of my researchers, Sebastian, with a postdoc, he works more and more with alternative data sets, and especially big data like big social media data, Twitter and Facebook. Here it's an example of a map derived from Facebook connections during a flood event in Belgium in 2021, where we can see the changes in population density. So no, it's not the change in population density, it's the change in the number of connections to Facebook for each pixel. But then we evaluate how well is the relationship between population density and Facebook connection. Of course, there are lots of bias, but given the number of people connected to Facebook, it's quite, you can still extract useful information from that kind of database.
So the flood was there in the pink area.
So in the pink area is the area where the people stay still, didn't move.
Okay.
So and yeah, you see where in the valleys where there were heavy floods, the people didn't move or move before maybe sometimes, but yeah, this movement. And then yeah, the second point, so this is just about the connections, but then you can also look at other social media like Twitter, where you have also textual information. And this is the second example, still on the floods in Belgium. We can extract dominant topics in tweets, in geolocated tweets, and then map them, and it can give quite interesting information and real-time information actually. Here it's about the main topic is heavy rain, and so we can identify where the heavy rains are based on tweets. Of course, it's not perfect. Again, there are many biases, but it's quite interesting because we can really see interesting patterns in that kind of data. Yeah. Then. Yeah, I should have put that slide before. Sorry, it's related to the vulnerability, but more. I wanted to mention also that we did some work on access to health centers. There are two PhD students that worked on that. The second one, Moses Musso, is just starting. The idea is to characterize the access, the geographical or physical access, but also other kind of access, like you also need financial and different facets of the access to health. We have also worked on the questions of catchment areas. You know, when we have data, disease case from a hospital or a health facility, we often need to define the catchment area to use the data to calculate an incidence rate. We need to know the denominator, so the population around the hospital, the population that is living in the catchment area. So we did some work on that as well. But again, that's just wanted to mention that's another part of our work. Okay, now. Sorry, I'm talking much.
We had issues with the microphone, so.
Okay. So I will present 3 current PhD projects now. I will not talk about José's work because she had the chance to present it in June. but I will focus on 3 others. The one from Camille, I already talked about Camille, she's the one who worked on the interpolation of DHS indicators, but she worked on Senegal, on malaria risk in Senegal, and she did some spatial-temporal Bayesian model based on malaria prevalence from surveys, DHS and MIS and other surveys for which we have point data with prevalence. She included environmental and human factors because she did a big work on the prediction of vulnerability or human layers. And also the work is stratified by endemicity zones because in Senegal we have very clear, quite different endemic zones, with the north that is close to extinction, for malaria, the prevalence is very low, and then the southeast that is more endemic for malaria. And yeah, she tested models where she included no predictors or only hazard variables, so only environmental variables, only vulnerability or hazard and vulnerability. What we can see is at least at the national level, so the national models are the one on each time on the left, including both hazard and vulnerability is always better. It's not the case when she worked only on the KKT models. KKT area is the southeast area. The problem here is so we see that it's not better if we include vulnerability variables. There is a question of seasonality here too, because the surveys done in the KKT area were done in the dry season, I think. And not the wet season, and so it has an impact on the relationship that can be identified in the models, like the environment. The environmental variables are more important during the dry season than the rest of the year. Yeah, and she did a work also of comparison between prevalence and incidence. So prevalence on the, so it's the A here on the top left, is based on survey data, the ones I just presented before. And incidence is based on the human cases recorded at health facilities. So she had a number of cases from health facilities, but not knowing where people live. So they don't have the residence information of the patients. But she related the number of cases to the catchment areas she calculated around health facilities. And so we can compare the two maps with quite different spatial patterns. And yeah, both information are important, but yeah, they are also complementary. It's quite interesting to compare. There are lots of questions about data quality and completeness and everything. So it's interesting to have both, actually. Okay, another project is about mosquito-borne disease in urban East Africa. Here, Noel Joseph, so another PhD student, is looking at the co-occurrence of different diseases. There are very rapid urbanization rates in this area, and there is some people are more and more worried about co-occurrence of the different vector-borne diseases in these rapidly changing urban environments. So the idea is to see where we have co-occurrence of dengue, chikungunya, and malaria, and look at the intra-urban variability for that. She will do same kind of work I showed at the beginning of the presentation for Dakar. So trying to map at very high resolution the potential distribution of mosquitoes, the different species, and include also some vulnerability variables to predict the spatial distribution of the different diseases. So
she use an analytic hierarchy process, and that will be based on expert weight. So she's asking experts to qualify the suitability of different environmental variables to the different mosquito species, because we don't have enough mosquito data to do that, the work to train models, very high resolution models. So all this is based on expert knowledge, and we'll see how we can see different weights to assign to different variables according to the different mosquito species. Yeah. Yeah, that's it. Then the last one I wanted to talk about is not about or not only about mosquitoes, but it's more about the risk of zoonose emergence in Cameroon. It's Ines Sobre, and she's developing a participatory risk assessment. So the idea here is to ask also experts. So in the field, you go to ask experts to identify the risk factors, and using a calendar like that with seeds, they ask people to attribute or to assign weight to the different risk factors they identify. That will also be used to produce a risk map. So she will try to collect as many as possible of the environmental and human layers she related to the risk factors she identified, then assign the weights. And this is done by months also. So it's also a temporal, a dynamic risk mapping. This is ongoing, so I don't have risk maps to show yet. But these are the results of the only for Rift Valley fever, the results of the different risk factors identified. So you see the first ones are mosquito density, rainfall, transhumance, livestock trade, etc. And then the variation by month. So this is extracted from the expert interviews, from counting the seeds. Okay. Yes. And you see also here the number of seeds assigned to each risk factors. Mosquito density, rainfall, etc. And she can compare also with Ebola, and she works on Rift Valley and Ebola. And what is also interesting here is that she did also a big literature review, a systematic literature review to extract the risk factors from the literature, the scientific literature. She assigned weights based on the literature, so based on the number of times the risk factor is mentioned, also using statistical significance, that kind of thing. So she had a list of risk factors with weights from the literature and then weights from the expert, and she then could compare and identify some of the risk factors that were, for example, livestock trade, never mentioned or almost never mentioned in the literature, but much more mentioned by experts. So the ones in orange and red are the risk factors that are where there is more divergence between literature and the experts. Yeah. So yeah, this of course demonstrates the value of integrating some expert insights with empirical data, and also to include some local contextual information in the models. Yeah, I've finished with a slide with some of the main challenges we face for all this research. Sometimes it's quite intensive, high-resolution data collection and processing. Of course, not all variables can be measured, and some remain unobserved. We will see with Ines' work I just showed for Cameroon, there are clearly some of the risk factors that were identified by experts, but we'll never be able to map. And that's one reason also why it's not in the literature, because we cannot measure them. There are always challenges linked to data limitations, mainly epidemiological data, but not only. I mean, regarding human factors, census data, we are always limited as well. We need to fill gaps or to adjust due to the data limitations. Yeah, and the small drawing here is just linked also to the spatial precision of the data. For example, for survey data, we don't have the exact location, and we have to also acknowledge that. Last challenge is also to bridge the gap between fundamental research and local impact. It's always something to keep in mind. It's not doesn't make sense to produce fancy and complicated maps if it's not used afterwards. So it's an everyday challenge to make things, to make an impact locally. And participatory methods, the ones Jose is using, is also helping to involve locals to bridge that gap. Okay, thank you very much. So as I said at the beginning, it's not my work, it's the work of the whole team. Feel free to I'm still here the whole afternoon, so if you want to discuss some of these aspects, happy to do it. Thank you.
Thank you, Catherine.